I would say that, start because, we got one, so, but that's crazy.
I got you.
Then I'm just next to it.
Yes, sir.
But it's the details, you know, in the, yeah, but it has some good stuff.
As always. Would you like yours?
So, but have to deal with all that.
Oh, no, you're
It's so easy to see.
Yeah.
She did us a trouble.
Hey, how you doing? Doing well. Are we okay?
Yes.
Oh, digging it. Call me before I embarrass myself.
That pony. Jay, you ready? All right, we're gonna call the employee benefits meeting to order. We'll start off with the prayer and pledge. We'll do the, prayer by Ms. Easton and the pledge being by Mr. Easton.
Father God, we thank you for your presence among us always. We ask that you send your spirit and guide us as we make decisions for the greater good of the Calcasieu Parish School Board and its employees. All these things we ask in the name of Jesus. Amen.
Amen.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Roll call, please.
All right, Mr. Billy Bray,
Here.
Ms. Linda Gay, Ms. Phyllis Ayo, Mr. Sean Bumgarner, Mr. Damon Hardesty, Mr. Tony O'Banion. Here. Mr. Patrick Pichon. Here. Dr. Suresh Chiraguru.
Present.
Ms. Vanessa DeVille.
Here.
Ms. Beth Eason.
Here.
Mr. Troy Fontenot. Here. Mr. Wayne Foster.
Here.
Mr. Mike Hill.
Here.
Ms. Holly Howell.
Here.
Ms. Annie Mouton.
Here.
Ms. Renee Oakley Rule.
Here.
Ms. Lori Smith. And Ms. Ava Sullivan.
Here.
Chairman, you have a quorum.
All right, so we've got 4 items on the agenda tonight. Number 1, I'll let y'all have it.
Hey, thank you so much. Hi, thank you for having our meeting again tonight. Good to see everybody. With us today, we also have additional people from our Louisiana Blue team, so I want to go ahead and introduce those. Valika Hurst Trahan, of course, our account manager in the Lake Charles region, and she's been with us I don't think you've missed any. Brian Cruz is our account executive who handles this territory, so Brian is with us. And we also have Greg Hanley, our regional director for Louisiana Blue, all servicing and a part of the team for Louisiana Blue assigned to your account. So I'm glad they're here. And of course, Richie is with us, and John Garber is on his way. So he was detained at another meeting. So with that, we're going to go ahead and get started. And we're going to kick off with pharmacy, always a hot topic, right? Our pharmacy benefit manager is Chromedale Express Scripts, which we moved to 2 years ago. And we actually were coming out of our initial phase. We had another year locked in with them, but things moved so fast in the pharmacy world. We went out and negotiated contracting. We did a market check, and our team, led by Brian Friedgenberg, who's out of North Carolina, he really squeezed hard and negotiated well for you and wound up coming up with a contract, a new revised contract that's estimated to save 23.34% or $4.5 million. That directly affected your projections for the upcoming year. So that new pricing was really a part that helped impact a better renewal for you, right? So very excited about that. We talked a little bit about that at our mid-year meeting, but I just wanted to kind of reiterate that. Also in the past year, we improved some programs. We went to an unlimited advanced utilization management program that was implemented September 1st of 2025. The plan previously, slide there, not keeping up with my slides. The plan previously had ESI's advanced utilization management program, but this unlimited plan is a more extensive plan that ensures drugs are being prescribed according to FDA and manufacturer recommendations, and it includes all lists that ESI offers to meet the prescribing criteria. We also added an advanced opioid management program, which was implemented. And it's just a more robust way to make sure that there's additional monitoring around opioid usage and counseling therein. So we're very excited that that was added. In addition, we enhanced and continued with your Safeguard pharmacy programs. It's kind of hard to read there, but we have cardiovascular, oncology, diabetes, care value, inflammation, multiple sclerosis, some rare conditions with the core value program, neurological care, and also market events protection program. So if something comes new to the market, they don't just automatically start paying it. There's a block in place, right? Let's evaluate it and make sure that the latest and greatest and most pricey is has some efficacy and some proven results around it, right? There is a discontinuation credit when meds are no longer needed, and somebody's prescribed a new medication, and let's say it doesn't work for them. They have side effects. So if that happens and that prescription is discontinued in the first 90 days, the plan gets a credit back for some of the spend that you made there. So really good layer of protection for you there. Next up, we've talked about this a little bit, but I wanted to reiterate that we have that good RX generic drug pricing seamlessly pulled into the plan at point of sale. Now I say seamlessly, what they're doing is the pharmacist is it's through the Good RX and Express Scripts program called Price Assure. And the pharmacist is going to ensure that you're getting the best pricing. Now, sometimes it's not as real time as as we would hope, and sometimes we might have to go the extra mile and ask. What we've learned is that GoodRx may offer additional discount programs at a pharmacy level that are not included with the Price Assure model, right? And there's some timing differences between drug pricing updates from GoodRx and Express Scripts and the impact on that claim is eligibility as well. So, but for the most part, everything kind of flows through very seamlessly and helps to save your members money in terms of co-pays and outlay. Yes, sir.
I know 3 people, including myself, at bar, you have to request the GoodRx.
Yeah, we
When
have,
it was billed as point of sale pricing.
yeah, we did research that and reached out to the pharmacy team as well, to try and put a block in place for that. But that, I think, was, and Stacy, you did a lot of research on this as well and have the talking points, but that was a layer of some changes that weren't updated right away. They were at the pharmacy level, but they weren't built into the Price Assure yet. It wasn't in that model. I believe that was the situation for all 3 of those people, right? Yeah. But yeah, good.
So it's not at point of sale.
It is generally at point of sale, yes. But sometimes there's a timing difference or a pharmacy level discount too.
One of the first 2 we discussed were, I know those were the same medications. Was the third the same medication? Would you happen to know?
No, I don't think it
Without
was.
naming any-
No, I don't think it was.
Okay.
Yeah.
We'll go deep on.
Okay, very good.
I have a question before we go much further into this. With the GoodRx and the Express Script, I'm speaking from personal experience. I received notification from Express Script because I have the Blue Cross insurance with the school board, and they told me about 2 items that my physician would need to change because it was not a part of their formulary. I've been using this for about 2 years now, and they've never paid for it. It was always out of pocket for me. And I'm just wondering, I'm just getting a letter saying they're not gonna cover it when I know for a fact that they've never covered it. And it's the Libra monitoring device. They've never paid for that. It's always been out of pocket for me. But this last time when I went to the pharmacy to pick it up, there was no charge for it. And I thought they had made a mistake because I always paid for it. But then I got something saying that they were going to give me a month's supply. And I was just confused with that because how can something that I've always paid for and you never paid for, now you're giving me a month's supply? And I'm just wondering, should they have been paying for it? And that runs me about $160 a month for the 2 boxes.
We'll have to research specifics, so if you could email me this, what you just announced.
Okay, I'll make a copy of it and bring it to you because it really confused me if you're not going to be paying for something that I've used for 2 years and
Well,
paid
then
for
you're like,
myself.
hey, I might be able to get it paid.
So now they're telling me that it's not a part of the formulary, but it was never a part as far as I've used.
Right.
Just asking.
So there are 2 things. I'm sorry, Stacey. I want to address the formulary list first. Those do get updated a couple of times a year. And generally speaking, in January, we update formulary lists. It's just a general industry-wide standard. So we do see formulary shifts that happen a couple of times a year. Now, go ahead, Stacey.
Ms. Gay, if you'll email me and Stacy, we'll look into it and find out exactly what's going on.
Okay,
'Cause-
I might be able to show you now because I have it in my car.
We'll look at it.
Okay.
We have to leave
Hey,
here.
hold on a second. Let's contain the business to what we're here for. Personal things, get with staff on an individual basis. Let's continue what we're doing here.
Okay.
Well, forgive me, Mr. Burr, but when I was sitting in the audience, I thought I heard them talk about RX and Express Script, and that's why I would say out there for
Yeah,
me.
that's what they're bringing up, and on personal things, we try to do those on an individual basis.
Okay, thank you.
But to the more generic question of formulary lists, those do change a couple times a year to keep up with, the changes in the pharmacy landscape. So that's a generic question, very good question there. All right, Any other questions on pharmacy before we move on to the medical side and the drum roll for like, what are we projecting?
And this may have nothing to do with it, but the last time that my husband ordered some medication, he's taken it for the last 3 years. I think it wasn't Express Scripts that contacted us. It was Evernorth.
Evernorth, Cromdale, and Express Scripts are all,
Questioning the medication that my doctor prescribed for my husband.
that's what their job is.
It took us over a week to get his medication.
Okay,
Now, how do you, I mean, that's not,
so if you reach out to staff, they're always willing. We have team members in place that service and are very responsive to the school board anytime there's a specific question to address. So they're always here to help. Our team is here
so
to
is
help
this
as well.
something that the member, people that have insurance can expect to incur? We've never seen it happen before. Is it something
With
that's
some of
gonna
these-
happen more and more?
With some of these programs that we're implementing, there's prior authorizations that we go through to make sure that the medicine that your husband's getting is exactly what he needs. Sometimes especially on specialty medications, there are additional layers of prior authorization that are implemented to ensure that everybody's on the medication that is not only most effective, but also the most cost effective. What's that?
Shouldn't that be his physician's decision, what medication he should be on?
The physician always has a peer-to-peer opportunity to review things, but there's also a team of specialists, especially when you're talking about specialty medication. There's always a team of specialists that study the efficacies, and they have all the latest protocol and how to get it, and they also get the best pricing by using a different pharmacy perhaps than, a local pharmacy. Although for the specialty program, we do also have a local option with Memorial Hospital's specialty pharmacy. So it sounds like he's on a specialty medication.
It's his Ozempic, he's taken it for 5 years.
With Ozempic and any GLP-1 in particular, there's monitoring and tracking that goes within the industry to make sure that it is for diabetics, which it sounds like it is, and that the results are there. They do additional monitoring on that.
There's
That's
a lot
a
of,
standard GLP-1 monitoring.
there's a lot of
That's
documentation
industry-wide.
that has to go into it. And if there's any lack in documentation, there's prior authorizations that they have
My
to
only
take.
problem was the questioning my position, or his position.
That's their job. We have these programs to question the physicians to make sure that
So they decide
utilization,
that they don't think he needs it, they can't.
if he doesn't provide the documentation, he might not.
But again, the bottom line is on a personal level, you take that to the team so that they can advocate for you.
But
But
in general, so that
Yes.
when I have somebody else come up and say, hey, this happened.
So the dollar spend for pharmacy has crept from maybe 15 cents on a dollar all the way up to it's projecting to be close to 50%. Pharmacy has become such a large component of not only how we treat diseases, but curing diseases with gene therapies and such. I mean, it's big money. Like we've had prescriptions within this group over $1 million a year. So, something that the school board and the team and our financial team and our pharmacy management experts really drill into to make sure that we're spending the school board's money wisely and we're doing everything we can to make sure the programs are in place to help the patient have good outcomes and also that the plan is spending money where they should be.
It's not micromanaging the doctors, micromanaging the spend to make sure that everything is being sent out the way that it should be and that it's the best for all involved, especially the patient. When the doctor comes in, if it's just didn't submit the right documentation, then that's something that they deal with all day long. They, just maybe miss a form or something like that. But again, on personal things, I can understand where you're coming from, but let's try to stay on task on this. Because if we all get into personal things, we're going to be here until midnight.
They're happy to stay after.
Yeah, but that's what the department's here for and stuff like that. They can explain and do a lot of that stuff.
Okay.
Go ahead.
So pharmacy, again, always a hot topic, right? Very near and dear to all of our hearts. Moving on to the medical spend and the drum roll, if you will, the arrow there points to a number that's surrounded in red, and that's 6.8%. That is what our financial team at Hub is forecasting for the current trend for next year, the amount of money you need additional over what you're budgeting now, right? So given that we're not in double digits, and many of our groups are right now, it's kind of a little bit of a sigh of relief, but we do, and we're very mindful that dollars are dollars, right? So how do we get to that 6.8%? We look at our current experience and we weight it a little bit more than the prior year. We look at trend of 6% for medical and 9% for pharmacy. That's all pulled in with what are the administration fees to pay Blue Cross to monitor and to process all those claims and to maintain that good network that you enjoy, as well as on the pharmacy side. We have stop loss premium. Any claim over $750,000 is pulled away from your experience. We have an insurance policy in place for that, and there's a premium of about $750,000 round numbers for that. So when all those numbers are factored together, the annual change that that the financial team has projected that you're going to need more than you're budgeting now is $3,692,203. Moving forward, some additional factors that impact your renewal. The claims experience ran well over budget, 7.1% increase, is projected 7.1% over the prior year, but we had some things helping that. You remember when we were here at mid-year review, for those of you who are in attendance, we were actually spending over what we had budgeted by 2.8%. So we had been talking about that then. We made an adjustment to the claim database on changes in tiered enrollment. What does that mean? We're having more enrollment shifting to that high deductible plan. We had 11% more in the past plan year that moved over to those high deductible plans, right? And off that traditional copay, that high option plan. So we're looking at that. We're also looking at that renegotiated pharmacy contract to see the financial impact to the betterment of the current contract. So squeezed a couple dollars there. We're looking at a claims reserve of 2%. That's, rainy day. And the inflation we already talked about. The stop loss premium went up 7.7%. The admin fee did not go up from Blue Cross. We're in the middle of a 3-year rate hold with them. So we have a 3-year contract with them. So that gives you a lot of stability there. So the projected increase to medical plan budget is 6.8%. And the financial impact on that is $81.81 on a composite level. Now, last year when we were sitting here, we were looking at almost twice that because that number was at $153.19. So again, relatively speaking, good news there. But again, mindful that dollars are dollars. Any questions so far? All right. Stated again a different way, just restated. All of the number crunching with the claims adjustments and all the financial figures are there. But not to delve too much into that unless somebody wants to. I'd like to flip to the following slide, which is our high dollar claimants. Total dollars recovered in our prior plan year when we were sitting here, we had 2 claimants to the tune of $1.3 million recovered back into the plan funds for that insurance policy, right? Year to date, we don't have any money coming back in for those high dollar claimants. Now, we still have high dollar claimants, but we haven't hit that threshold of $750,000 yet. Now, historically, in this time of the plan year, we start seeing them all start getting to that number. And the average right now for the 5 claimants that we have over $375,000 is, because that's half of that 750, that's why that number. The average for those 5 is $523,000 each. So you can see how they start get more claims in the next quarter. We're going to see that get closer to that 750,000. Your current premium is $720,960. The renewal premium is $776,813. Okay, so I think we did the math on that, and we came up with the impact per member, and it was, what was it? I don't remember now. Yeah, it was like $1 something. Yeah, I knew we did the math on it. Premium plan history. It's good to kind of go through that. So we've outlined from 22 on forward. In 22, 23, we were at 12.45%. We made some changes as noted on the side with some copays. In 23, 24, we had a better year. Everything's kind of cyclical. We had 5.17% plus some high option changes. The high option meaning that copay plan We changed the deductible from $750 to $1,250 and $3,000 to $4,000 on the out-of-pocket amount. And that hadn't been changed for quite some time. In 24-25, there was a 4.9% increase that was absorbed by the board with no plan changes. And then last year, we had a 12% increase with some offsets by some changes to, mostly to that high option plan, bumping up some co-pays, bumping up the pharmacy deductible, which had been in there since the 90s, and changing that from 100 to 250, and changing some co-pays on the tiers for the drugs as well as the out-of-pocket. Max went up $500 or times 3 per family. And we added in a new mid-option $2,000 deductible plan, and really the recommendation of this committee. All right. The next slide is and I apologize, I would put this on really big paper if it were up to me, but it doesn't look good in a booklet here, but hopefully you can make this out. The premium recommendation, this is just what we really work with Stacy and Jay on, what do we need to budget for this? And if we take that 6.8% and we apply it across the board, just like everything is today, you can see the dollar impact there. So as an example, on the high option, the current employee contribution is $403.34, and if you move over, go to $430.76. So about $27 round numbers. And then if you look at like that low option, which we have a lot of membership on, is $201.69 now, going to $215.40. So about $14 change or so in a month for an employee impact. Yes, ma'am.
Are the people on Medicare considered in here?
So no, they are not. Well, if they participate in this plan, they are. There's about 400 contracts that are on this plan. Okay, that are still on this plan that are Medicare eligible. For those that are in the group Medicare Advantage plan, which we actually have a slide on in just a couple of slides, no, they're not part of this. Yeah, and the plan is still saving money by having them on that group Medicare Advantage plan. And they've got a $0 copay plan. It's a pretty neat deal. It's a good question. All right. The next page is recalibrated defined contribution, because we've been asked along the way, what would this look like if we just said the board's gonna spend X amount? And that's what this next slide does, or this next example. And what happens is there's a lot of disruption to the employee premium, especially shocking for people who are covering families. So if you follow that in, and this time I'm gonna pick on a family, you have in the high option now, $1,159.64 would slide to $1,839.44, as opposed to like $1,200. So it'd be like $600 more, right? So when you go to that defined contribution and you're not paying, because historically you've been paying the 62%, 50% of dependent coverage, this other way, you're just saying, we're gonna spend X amount per contract period. And so some people win, but a lot of people don't win, and it's very disruptive, right? So we did want to at least model that for you and show you what it would look like, because we've been talking about it here and there. Not that, it's come out as a suggestion, just that we need to kind of start looking at those numbers. Any questions on that?
You mentioned 11% left a high option plan.
Mm-hmm. Yeah, left the high option plan for the others.
Well, since the mid is new, I was just curious.
So the mid option, you'll see that right there, the numbers off to the side. We had 74 employee only, 9 employee spouse, 13 unemployed with children, and 4 with family. So not a huge migration to that plan. Yeah, smaller migration to that plan, and people just jumped into the other plan for the premium differential at this point, but it was a new plan, first year. Takes people some time.
I have a question about that too, while we're talking about that. With 11% moving to the cheaper plan, how did that impact CBSB's contribution into the insurance, given that they're paying 63% of the premium and you had 11% move to a lower premium? What was the total cost or the total impact to CBSB's contribution to the health insurance, given that?
I'm gonna let you address that, Jay.
I brought this up at the last meeting.
Yeah.
I don't have that figure. we can figure it out. But if I want to say everybody moved from the high option plan to the low option plan, it would have a significant impact. I think it was,
20 million if everybody did.
there's
Yeah.
20 million. I think if half went, it was like 9 million. It was a pretty significant jump. So if the migration gets stronger, there is another conversation that we'll have to have in how exactly we're funding this. When it causes a lot of disruption on their part and skews the percentages that the board is contributing to each plan.
Mhm.
And we have to break away from the 63.75 and 50 for dependents.
I understand. So look, when we were managing this as an attempt to manage the costs, it was not the intention, I don't think, of the group to reduce the amount of money that CPSB contributes to health benefits for its employees. And as just a matter of practice, because we're paying a percentage, any change we make that lowers premium is going to lower the amount that CPSB contributes for this purpose. I don't think that was our intent. So the reason I'm bringing this up is that if there is an increase that we have to make in terms of premium, we would want to keep the contributions that CPSB makes into the insurance at the same level. And, I've kind of made this argument a few times. It should be, I think, at a flat level. If it's 10%, if it's 11%, whatever it is, so that our finance group can expect something and have that number be stable, but at the same time, give us flexibility to work within premiums to do what makes sense for the employees without reducing the burden on us.
Right. And to your point, if you look at the number here, it's that 35 million, it's the same 35 million down at the defined contribution. Does that make sense? So to your point.
I'm sorry, I'm not sure.
So if you look on this first model, that you'll see under the projected employer contribution in the blue, it's the 35 million, right? You see that up here?
No, I'm sorry.
Highlighted on the computer.
Okay.
So,
Here, get them out,
So
right there, yeah. And then if we go to the next one, it's the same 35 million right here, like if we went to that defined contribution. But to your point, the employee premiums need to equate to that number, and the CPSB needs to equate to that 35 million, if that makes sense.
So the 35 million, what was the contribution last year?
It was over to the left, it was 33 million. Employer contribution, if you go to the left, in that first section, like in this section right here,
Oh, it is.
like you see that right there?
Okay, thank you.
Yeah. But valid point. And one that we keep looking at different ways. Okay, moving on. Wellness program, take it away, Jay.
All right, so we had our wellness fair again in September. This past year had pretty much the same participation that we did last year, about 60-40 actives to retirees. Retirees really enjoy it. It's a good social outing for them. Stayed steady, 425 participants. We've already set up ours for this year. This year will be a little bit different. It'll be October instead of September. And we'll have it here in the main office. Our date got bumped by the Lake Charles Event Center, so we figured we'd save a little bit of money and just have it here, and we'll have it when we want. And so we'll try to get some vendors back. We're sure we're gonna have to reduce it just to do the difference in space here, but we will have it here. We did kick off our Walk to Wellness program in 2025-2026, starting in the fall. And we had 275 competitors that completed the program in the fall that did not participate at all last year. So instead of having about 325 participants, we're about 600 now. So we almost doubled the number of participants in the wellness program as a whole, which is wonderful. And we really want to kind of try to keep pushing that. We've had a lot of positive feedback from schools, which is trying to grow the group at each school. But the wellness leads at each school have done a wonderful job in getting some people together to make it a friendly competition to compete in the Walk to Wellness program at their school. So we went around in line 2 weeks ago and took some pictures of the winners and gave each of them a banner to have to hang in their school for the spring, and then we'll do it again at the end of the spring. And so those all those competitors that completed got 2 wellness points towards a total needed of 8, and this year, like the board approved last year. We went from 5% discount on the employee portion to 10%. So hoping to push that a little harder and get that word out there that you can get a 10% discount on your employee premium.
Good. To your point, ma'am, next up is the group Medicare Advantage renewal. In 2026, we have January 2026, we had a 14.8% increase to this plan. The financial analysis that HUD did shows that your group MA plan is saving the commercial plan, the plan we've been talking about, $121 per contract per month, okay? So that adds up. In January 2027, the group Medicare Advantage plan will be up for their premium evaluation. We don't have the numbers at this time, but we expect to get them in the fall of 2026, and the team will be communicating that out.
I have a question before we read Medicare Advantage. I have found, and some of my friends and I have been talking about, a lot of the physician offices are saying that they will no longer take Advantage plans, and they are encouraging patients who have been there for a long time, like 30 years in that office, they're recommending that you get a supplemental plan.
So if they're with Memorial, talking about Memorial Hospital Group?
Mhm.
Okay, so I've been in contact with Memorial. If there's as long as they're an existing patient, they won't be able to continue seeing their doctor. They're not taking any new patients.
Okay, because I've been there for over 40 years
Yeah, you
at Memorial, and they kind of told me that some of my friends who are retirees of the system, who go other places, they're telling them that they need to research. I went in and asked, and they told me I would be grandfathered in, pretty much.
If as long as they're an existing patient with Memorial Health System, they will remain a patient.
Okay, but have you encountered anyone else that's not with the Memorial Group who are saying that the offices are actually telling people that they need to?
Not yet.
Okay,
Okay.
look forward.
If they do come up and say that, please have them call so we can address that office.
Okay, thank you.
No problem.
Great. All right, moving through to dental coverage. We've moved off the medical now, onto dental. Currently, you're with Humana. It renews 5/1 of 2024, and we're rolling off. We had a 2-year initial rate guarantee with an 8% rate cap for this third year, and they're calling in that rate cap because claims are paying out at 95%. So they need the additional funds of the 8% that they committed to back 3 years ago, essentially, or 2.5 years ago. So Humana, we went out, did a market check to see if Humana is still the best deal, and sometimes it is, and sometimes it's not. We had some declined quotes or not competitive quotes, and then we received 2 competitive quotes, one from MetLife and also one from Sun Life, that we'd like to present to y'all. So looking at the next slide. Your current information with Humana is in this first column right here, okay? So that's your current and your renewal, and you'll notice the plan is stable and staying the same. The rates are changing that 8%, which equates from a change from $35.35 for an employee to $38.18. And that's a 1-year rate renewal. Then next year at this time, they're gonna go out and they're gonna say, well, maybe we might need 20%, right? That's what we faced a couple of years ago when Humana came in. So that's when, we go back to market. Having only an 8% to compete against means that the carriers, if they're interested, are gonna get competitive with that 8%. And they did, they both matched that 8% rate. So it's all 38.18, but they're coming in with multiple year strategies. So we have a 2-year rate guarantee, then a rate cap of 7%, that then with Sun Life, that then MetLife said, okay, we'll do that too. The art of negotiation, if you will. Then we have a couple of additional benefits. You have with Sun Life, the $1,000 maximum plus a total rewards package. So what that does is it says, hey, you go for your 2 cleanings and your bite-wing x-rays. We're gonna credit the amount that you spent, that the plan spent on that, say it's $400 or $450, and they're gonna put that back to your annual maximum the next year. So now you have like a $1,400 maximum instead of a $1,000 maximum, okay? And continues forward. So if you're just getting your cleanings done, you can earn up to another $1,000 and have a $2,000 annual maximum pretty quickly, right? So that's a cool program that Sun has that is not matched by MetLife and kind of matches up to the opportunity with extended maximum, but it's actually more robust than the extended maximum you're getting currently with Humana, but it kind of matches up to that. One thing that I thought was pretty cool is that they cover the children for orthodonture up to age 26. And so this kind of matches up to that 26 that gets in our head when we're parents, like, oh, they're on my plan to 26, right? So they didn't get around to the braces and all of a sudden they've aged off. Currently it's 18, it's 19 with the offer from MetLife. This way, well, they're on your plan, you can still have that child, that dependent orthodonture till age 26. So that's pretty cool too as well. So the dollar change is consistent with all three. They've also, Sun Life also added in a additional pregnancy benefit that if you are carrying a child, your hormones are different and you have different needs, and you get an extra cleaning also during that time. So it's a third cleaning in a year. And they also have another provision that's in that same rider that allows some additional complications for medical, like hypertension, diabetes kind of thing. So they've added an additional cleaning for that. And that was at no charge that they brought that into you as well. Any questions on dental structure with these three plans? Okay. Moving on to life.
I do have, so what is staff's recommendation?
I have, it's a real question. I have Humana. It's been wonderful. Looking at the three plans, I think staff would recommend Sun Life. I think they have a competitive rate. We lock it in for 3 years. And the total rewards program is very similar to what Humana has. I think it'd be really valuable. I know I just put a kid in braces this year and it paid out $2,500 towards it. So it was really, really helpful. So Sun Life is doing more on top of that. That's what I would go with.
You'll have that ready for the board meeting?
Yes, sir.
And we do, we have obviously experience with both carriers. Both carriers have partnerships, high-level partnerships with us. Sun Life has a cool and unique implementation strategy. So we find them seamless.
Does it work?
Do we know if Sun Life, is it accepted?
Yes, the city of Lake Charles, as an example, is with them. And they've got it, we've done an analysis of the network. The network's actually more robust. The reimbursements are competitive to Humana, meaning you get a little bit more payout generally across the board than what Humana's current structure is. So we've compared all the top 60 codes. We looked at network disruption. Potential savings and out of pocket was forecasted at around $250,000 for member impact, to the betterment of the member.
So, Randy, I'd just like to make clear, with the PPO networks under dental, most dentists don't want to be in anybody's networks. So it is a very limited network regardless of who you're with. So what we do is we set your plan up to pay on what's called the 90th percentile of reasonable customary. So for a teeth cleaning, they line up 100 dentists in Lake Charles, pick the 90th gap, what's he charged for a teeth cleaning? Let's say it's $100. That's what we allow, okay? So we pay 100% of that with no deductible. But what's important, what we did was we actually lined up Humana, Sun Life, and MetLife for the top 60 codes that have performed to see where they were on their allowance. Good news is Sun's actually allowing more than any of the others. And so what that means is, let's say you went to the dentist and they're charging 110, and we might be allowing 110, you're not having to come out of pocket. Whereas if we're only allowing 100, you sure could possibly have to come up with $10.
Right.
So I mean, that's the difference in the allowable. I want to stress the plan pays the same 180, 50%, whether you're in or out of network. We're always careful to structure it that way because we know most dentists aren't going to be in anybody's network. Your top 5 largest providers of dental care for the school board are not in network. Okay, I happen to know 3 of them very well, but and so Med's calling me saying, we're gonna get them in. Well, no, you're not. I know them well, they're not gonna get in.
They don't want to be.
They want fee for service.
So, but just, again, if you change, you're not gonna notice any disruption in that regard. but the people may have to pay less money at the time since they're allowing for.
And the other thing to note is you do get an ID card with Sun. So that's something we get asked a lot. Not every carrier does that these days. Okay, moving on to the life then. Good news here. There's no change to the base life or the voluntary life rates this year. So nothing to really have to dig deep on that one. On-site, near-site clinic, Jay.
All right, so we went out to market and did an RFP for an employee health clinic, and we got responses back from 4 national companies and 3 local companies, and did a cost analysis and involving all of them based on their per member per month charges. What they would charge us per member per month in order to host the clinic. And if you look at the annual cost to CPSB, the cheapest of them is just under $1.8 million. The target for this was to reduce our costs on urgent care visits and avoidable ER visits, which totaled about $900,000, maybe $905,000 each year in the last 2 years. And so the cost of the clinic is $1.8 million, and we're trying to save $900,000. It's counterintuitive. So based on that summary, it's my recommendation that we not move forward with any of the respondents of the RFP, simply because it would cost us twice as much as we're trying to save to be in partnership with them. I'm open to any questions that you might have. Again, we did this nationally. The top 4 companies are national. That means they don't have a location in this area. We would have to provide a building or provide a clinic, actually 2 of them, before this part of the contract even came into play. The bottom 3 are respondents that have multiple locations in this area, and it's still very costly. Any questions?
And that's, no question, motion adjourned?
Well, I have the summary notes, which
Go ahead.
we, for the medical plan, the committee recommendation for board action, recommended funding increase is 6.8%. So there'll need to be a committee recommendation for board action there. The group Medicare Advantage plan, of course, isn't, we won't have that until the fall. The voluntary dental plan, the committee recommendation for board action there to move to Med or Sun, or safety net is an actionable item. And those are the actionable items.
That's it.
It's
One
easy.
question, yeah, right. So you mentioned the Medicare Advantage plan, but there are many retirees that are not on the Advantage plan.
There's about 400.
And 1 point,
So my question is, what will be the increase, do we know, for?
Their increase would match what the actives would be, so it'd be 6.8%.
Now, one thing before we go, remember last year the board came in and decided to bump up instead of doing the big supplements, and we're adding part of that in on a monthly basis, so that'll kind of offset what they're kind of seeing. So I don't know, we may want to look at adjusting that. You know how we added in on instead of giving the big supplement at the end of the year, we took part of that and added in.
And put it into their, yeah.
Maybe we can make a recommendation to the board to cover, add in a little bit more to help offset some of that. If there's room for what we're projecting at the end of the year. I know it's making him bumper up. Just food for thought. But the board did do that, and that helped out quite a bit. So I mean, they are getting it more on a monthly basis, kind of help some of it. So just kind of a reminder on that. All right, no further questions. Motion adjourned.
Mr. Chairman, do we need a motion to recommend the increase for health and for dental?
All right. So I hear a motion to accept the recommendation on medical plan.
I'll make a motion.
Motion second? Second. All in favor, say aye. Aye, opposed, nay. All right, recommendation for the dental plan. Staff's recommendation on dental plan, to have a motion? Motion second? Have a second. All in favor, say aye. Aye, opposed, nay. Motion passes. I don't think we need anything on the other two, do we?
No, sir, no other action.
All right, now we need the motion. Motion, motion second. Second. All in favor, say aye.
Thank you.
Thank you very much.
Yes, yes.